start the recording. And if you're not speaking, if you could mute your screen, that would be great. Okay. Yep, you should be able to share your screen. There we go.
Excellent. Thanks, Jeff. So I'm going to be presenting a case of COVID-19 myocarditis. I know we said last week, no more COVID-19, but this one I think might be a little bit different. So this is a 51-year-old person, very physically active, works as a manual laborer, no underlying medical comorbidities. And you can see the other relevant clinical history here outlined in red. Early on fever, viral prodrome, notably on labs on day 7 infection, they found a lymphopenia, and then presented with AFib with RVR. And had an elevated BNP, had an echo that showed a low ejection fraction, and then subsequently later tested positive for SARS-CoV-2 on PCR. So here's the initial chest radiograph, and this was actually read out by one of our ER attendings who thought there was some pneumonia in the left lower lung, which I thought was a very astute observation. But otherwise, you can see kind of non-specific little strandy things elsewhere. So nothing particularly telling there. Here's the corresponding images from the MRI, and you can see in some of those areas that we see on the chest radiograph, some increased T2 signal. To my eye, it doesn't. While this could be atelectasis, the vessels don't look super duper crowded. And the paraspinal, the medial paraspinal spaces are relatively spared. And then you can also see there's some here up here in the left upper lobe as well along the fissure. And I think that would be a little bit less typical for atelectasis. So unfortunately, despite that clinical history, this patient did proceed to the MRI scanner. I did not know about this case until after the MRI was done, and I looked at the chest radiograph and read the clinical history, and I called the MR tech and said, hey, we should be worried about COVID, and they tested and it was positive. So here is the, I'm sure many of you are familiar with the Lake Louise criteria. There are 3 revisions, 1998, 2009, and 2018. The latest revision in 2018 requires T1 mapping. Unfortunately, we have a MRI software from 2005, and I can't do T1 or T2 mapping. So if we look back in 2009, the Lake Louise criteria, some of them include things like global T2 high signal, and then if you zoom in a little bit down here on this bottom paragraph, you can see that there's also global T2 signal, which is defined as any instance in which the myocardium is greater than 2.0. A little hard to tell without actual T2 mapping software, but I can show you certainly some areas where there's increased signal focally. And then also, importantly, in cases of myocarditis, because the muscles are often abnormal in the setting of a patient with myalgias, you can't necessarily use the absolute early gadolinium enhancement ratio of 4.0. Instead, you want to look at absolute myocardial enhancements of greater than 45%. These were subsequently changed in 2018 and shifted more towards a T1 mapping. But again, like I said, I can't do that. I'm sure there are other centers that can't do that as well. So if we look at this is the T2 black blood with fat sat, you can see there are certainly areas of focally high T2 signal within the myocardium. And then, but it's distributed throughout. And if you start throwing ROIs on there, you can see that compared to the skeletal wall muscle, it's certainly elevated. And if you look at the fat sat images as well, and compare it to the T1 pre-contrast images, certainly elevated as well. And when we throw some ROIs on there and start calculating things, we found that while the EGER was not super duper high, it was less than the threshold of 4, the absolute myocardial enhancement was 168%, which is greater than the 45% in the 2009 criteria. In addition, the skeletal to myocardial muscle T2 ratio was 2.6, although that's limited by the fact that we can't really evaluate our global T2. In addition, this patient has other typical findings of myocarditis on MR, including global LV dilation and dysfunction. So if you watch the cine here, you can see this left ventricle is markedly dilated with respect to the right ventricle, and global hypokinetic. Despite that, really nothing in the lungs that look like pulmonary edema yet. So this guy unfortunately proceeded to have some other complications. So here's images from a neck CTA that was obtained a few days later. kind of confirming some of the things that we saw on the MRI and the chest radiograph, that they have these patchy peripheral areas of ground glass. Here you can see some along the left upper level along the major fissure. And then unfortunately, that's as far down as they went on that next CT. This was done because the guy developed new stroke-like symptoms. And you can see here in the frontal lobe, there's new infarct. And this was actually a result of a new LV thrombus that he developed in the 2 or 3 days between the MRI and this exam. And that was confirmed on echo. So my point in showing this, I think, is not really so much to show what the myocarditis looks like, because I think that that's mostly a clinical diagnosis. I think it's just a good word to the wise for all of you guys out there who are doing cardiac MRI. Just be careful. If you see an order for something like myocarditis, or evaluate myocarditis versus sarcoid in the next few months, just be cautious and look at the chart a little bit closer and have a low index of suspicion for saying maybe we should test for COVID-19 first, because it's otherwise you could risk exposures to staff members and other patients. While this is mostly a clinical diagnosis, there are probably some characteristic imaging findings as well.
Thank you, Brian. I should also add there's a couple of new articles in JAMA Cardiology talking about myocardial involvement. While not perfect studies, it does at least, they do look at some risk factors for death, and there's clearly some papers coming out suggesting that myocarditis may be a major component, but just worth looking at. They're not perfect studies, but they do at least bring it to light. All right. Who would like to go next?
I could show a couple this week, Jeff.
All right, I'll make you the presenter.
So this is a 23-year-old man who came in with fever and a cough and has this pretty subtle low-grade consolidation, but this is not unusual in this situation. So this stuff in the left upper lung was visible at that point and became a lot more apparent within a couple of days. And his COVID nasal swab was negative. But along the way, his COVID swab converted and it became positive. And this is the radiograph taken yesterday on the day he died of hypotension. He probably had cardiac involvement, but this is his last radiograph. Just, low-grade patchy lung consolidation here, but profoundly ill. A late response to the COVID nasal swab. It was not positive initially, but became positive later on. So, and not a lot of lung disease here, but there's enough to kill him, probably because of concurrent cardiac problems. So, let me show you another case. This person also has fever and cough, and has a history of being immune compromised by having been treated with methotrexate for rheumatoid arthritis, and then off the methotrexate, and they switched to a different drug, something with imib or imab in its name. And this is the 25th, and then here's what things look like a couple of days later. Much worse diffuse lung disease. It has this peripheral concentration up here, I think. Not so clearly peripheral in the mid lungs and bases. And here's what it looks like here on CT. It's a ground glass abnormality. It's got sharp definition against spared regions, so it's got that sort of geographic distribution. Again, very sharp boundaries against spared lobules, sharp boundaries up here too. Not much in the way of crazy paving. And COVID testing was negative, and we were considering that this could be a drug reaction. It still could be COVID because of the low sensitivity of nasal swabbing for identifying COVID and stuff like this, and this turns out to be Pneumocystis pneumonia. So pneumocystis in a person who was not lymphopenic and who had been treated with methotrexate and now had recently been switched to a different drug. And this person was discharged from the hospital a couple days later on treatment. So not every ground glass abnormality in this era of COVID is COVID. And here's a person who has a peripheral patch of ground glass up here in the right upper lung, and then somewhat denser consolidation, more extensive in the base. And this is on the 22nd. And then a few days later, here's about 8 days later, roughly the same findings. This has become maybe a little denser, maybe it shrank down a little bit, still have pretty extensive abnormality down here. It's trying to be peripheral. Here's what it looks like on CT. Upper lung, ground glassy stuff on the right, maybe a little bit of a nodular component here too. And then we have this peripheral stuff in the base. Looks like pretty well organized down there. It's not infarction. It's deep in the lung here, away from the pleura, down at the base. And this is not COVID, but this is Legionella in the setting of somebody with hairy cell leukemia. So lots of ground glassy things out there. And then I wanted to bring up an old case of a peripheral
David,
patchy.
question: was that which species of Legionella was it?
That was pneumophila.
Okay, so the more typical one. Okay.
That was not exotic. Okay, here is a person, I think in his 50s, who has this, was short of breath, had a cough, and has peripheral consolidation up here in the right apex, pretty subtle. Maybe something up here too, and then some patches in mid lungs and bases. This is perfect for COVID. And here's what it looked like initially on CT. It's very peripheral, patchy, ground glass consolidation, worse in the upper lungs, but staying way peripheral down here. Slam dunk COVID. But this is H1N1 influenza in the old days. And so it also had this, often had this peripheral pattern of ground glass that made people think about eosinophilic pneumonia in those days. So this this tendency of some viruses to go to the periphery like this, it was pretty pronounced with H1N1. We had a lot of cases with this peripheral distribution of ground glass abnormalities. It's what we're seeing these days. This man went on to have a very rocky course. He had ARDS, he had big cysts develop in his lungs, he had pneumothorax. And at the end of all of this is what he looks like now, about 8 years later. This is, I think, 2016. He's got this post ARDS pattern of lung scarring, which is often upper lung predominant, as we see very nicely here, and low lung volumes because of all of this. And I don't know whether I have a CT scan on him. No, I think I didn't include the CT scan. So this is post H1N1. You can see this upper lung scarring is causing the tracheal buckling here and the splitting of the carina. So this is we see this pattern of scar often in people who've had ARDS from other causes as well. So ARDS can leave you with this upper lung predominant scarring. So we may be seeing some cases that look like this as people recover from COVID as well. So I wanted to show you cases that look like COVID, but were other pathogens. And I think H1N1 is what comes closest to having a CT pattern that's very similar to what we see with COVID.
Yeah, and even just in run-of-the-mill influenza A, I don't know what the H in subtype is, but I had several cases in the past few months that are dead ringers for COVID. So I think reinforce the point, the lungs can only respond in so many ways to an insult.
That's right. And I had another case of, I could go on and on with this because I have an influenza case from last month too that looks like this. I also have metapneumovirus cases. These are all recent cases in which the differential diagnosis came up with COVID.
Yeah, I had a human metapneumovirus this week, and it's identical.
Yeah.
But luckily, most labs have good viral respiratory virus PCRs now that they can do that. Now, it'll be interesting to see if there's any co-infections with other viruses that I've not seen in normal patients. I've seen them in immunosuppressed patients that'll have RSV and influenza, but never, we'll see. Okay, well, thank you, David.
Thanks.
All right, let's see, we've got Howard and Peter on. Either of you'd like to go?
I can go.
Okay. Give you control.
The cases are pretty quick.
Okay.
So this is a chest radiograph of a young patient, 19-year-old, and it's really an eye test. It's just to show the importance of paying attention to other findings besides the lungs and mediastinum. But in this case, they have abnormalities in the bones, and specifically it's in the thoracic spine. And this is a case of a missing pedicle. So if you look at this thoracic body right there, it's missing the left. You can't really see the left pedicle, and you actually can't even see the lateral border of the vertebral body. So this is just a case of. So this is suspicious for a lytic bone lesion, and that's what that is. This is a case of metastatic melanoma, a young patient. Okay. This was a case that was shown to me by my colleague Art Stillman a few days ago, and this is also a young patient with breast cancer. This X-ray was done to evaluate her central line, her chest port, and she was scheduled to have to get chemotherapy in several days. And so when he looked at it, he didn't like the course of the central line, and the more obvious finding here is the central line is terminating here to the left of midline, and it's projecting right over the aortic knob. So this is concerning for an arterial course. And now the more subtle thing also to note here is the course of the line as it comes here. It's kind of contouring along the apex of the right upper lobe, and usually the subclavian artery has a more superior position anatomically than the subclavian vein. The vein tends to run a more gentle course here and then dive down. So the surgeons were skeptical that this was arterial, so they wanted to confirm it with the CT. And here's the CT, and that confirms it was an arterial line.
So how else were they going to explain it crossing midline like that?
I'm not sure what I'm not sure what their argument was. Once in a while, I guess you can make an argument if there's rotation, the line could project this way, but there's no rotation on this radiograph. You can see the.
I think, Peter, that was a surgically placed line.
I think this was a surgically placed line. Right?
Yeah. So they were just in denial.
Yeah, probably.
Wow.
Yeah.
That's a real phenomenon. That's why they should not interpret their own radiographs, because there's such an intrinsic bias against recognizing problems that they cause. But basically, even without that medial course, if a catheter goes above the clavicle, it cannot be in the subclavian vein.
Right.
So it never goes above.
And I think you can actually see the scalene tubercle where your mouse pointer is right there, and it shouldn't go above that either, because that's
right.
Because the vein is in front of that.
So yeah, and you can see the scalene tubercle a little bit better on this side, just based on the rotation. But yeah, it's probably there. I actually have the radiograph. This one.
Yeah, I mean, you could also just send a blood gas rather than doing a CT.
Right. Okay, and I have one last one. This is a patient, this is a radiograph right after he got a cardiac transplant. And you can see lungs are essentially clear here. This is immediately post-op. And several months he was discharged, and several months later, he came back, infectious symptoms. He has this large consolidation here in the right upper lobe. And then he also has a nodule here in the left lung. And of course, he was admitted and worked up, and he's found to have multiple sources of infection, including Klebsiella pneumonia by positive both blood cultures and BAL cultures. He also was diagnosed with invasive aspergillosis based on labs and histopathology. And then also he had CMV viremia. So it's kind of hard to pinpoint which of these abnormalities is related to which organism. Classically, the non-segmental right upper lobar consolidation is described with Klebsiella, and then these more well circumscribed nodules that end up cavitating. You can make an argument for invasive, either angioinvasive or airway invasive here. Fungus, aspergillus. I thought I could make a case here for bulging of this fissure a little bit posteriorly, which is one of the classic things with Klebsiella pneumonia. And then as far as the CMV, I think that's kind of also quite non-specific, could present with multiple lung abnormalities. But he eventually responded pretty well to antibiotics. This is a CT from several days ago. So a lot of these nodules are decreasing in size and healing with their cavitation, but he still has infection here.
Wow.
And that's it.
All right, thank you. Howard, do you have any cases?
Okay. Yeah.
All right.
Okay, I have two kind of interesting vascular cases. This is a person that came to attention as an outpatient for an aortic aneurysm, and you can easily see how big and dilated the ascending aorta is. The aortic valve and the aortic root appear to be okay. So it was decided to perform the operation for the ascending aortic aneurysm. As you'll see in a moment, the surgeon dealt not only with the ascending aorta, but decided also to put in an elephant trunk, the so-called frozen elephant trunk. So let me put this over here, and I will show you the post-op imaging. So a couple of interesting things. He resected the aortic aneurysm back to zone 1 of the aortic arch, and this diagram shows you the so-called zone classification that these surgeons typically used. So he went right down to the zone 1 at the level of the left common carotid artery, and basically replaced that, and then put in the frozen elephant trunk into the distal aortic arch and descending aorta. So let me go here and show you findings consistent with replacement of the ascending aorta to the level of zone 1 with a multi-armed hemoshield graft. So here is the proximal anastomosis at the sinotubular junction reinforced with felt. And you can see that they oversew the origin of the left subclavian and the left common carotid arteries. And going further, they then ultimately did anastomosis with the left common carotid And here is the anastomosis of the left common carotid to the native vessel. Here is the anastomosis, and I'll get to this in a moment, between this side arm of the hemoshield graft and native vessel. And then here is some irregularity where they did the anastomosis between a graft of the left subclavian artery to the side arm of the hemoshield graft. So that's interesting, but it's patent. I'm not quite sure why there is an apparent kink or deformity of that region. I think it's probably just surgical. And then certainly what surprised me was this. So now we have a dissection involving the innominate, the right brachiocephalic artery. Here is a fairly large defect. And then we can follow that along to the subclavian and carotid. So I don't know why that happened. I can just speculate. I didn't have the opportunity to ask the surgeon that somehow this was iatrogenic in some fashion as part of the operation, or just a complication of the operation. But why it's there and why it has that appearance, I definitely don't know. Of course, they've just elected to follow this patient to see how things develop otherwise, because the main operation was fine, went fine except for that. And here is the so-called frozen elephant trunk. I think he put that in anticipation of perhaps the need for surgery at some point in the future. I'm not entirely certain. This is a surgeon that does this quite often. If at some point in the future there's disease involving the descending aorta, they can use this, the frozen elephant trunk, as the proximal landing ground for TEVAR management of descending aortic disease. Has anyone seen this kind of dissection as an iatrogenic phenomenon in the context of aortic surgery in any particular way?
Not like that.
There's no description here of any kind of difficulty during the surgery.
I mean,
They do a right axillary artery cut down, Howard, for the cannulation.
That's a good question. Did they typically do go? I don't know.
You sometimes see it on the X-ray or on the scalp.
At the axillary, if we have surgical clips there. Yeah, I think they did use the axillary for the cardiopulmonary bypass, and I forgot about that. So I wonder if somehow that's a good thought, Peter, I think. If they used the axillary artery for the cardiopulmonary bypass and had a cannula in there for the bypass, did the dissection start there and then proceed in a retrograde fashion? Is that what you're thinking?
Yeah, that's what I was thinking.
Because there are clips there, and I think they did indeed use the axillary artery for the cardiopulmonary bypass. So that's a good thought, that it's iatrogenic, but it's related to that somehow. It is peculiar. Yeah, that's a really good thought. And then there was a re-entry right here into the brachiocephalic artery. Yeah, that's a good thought, actually.
I wonder if there's a concern if that could progress down towards the aortic arch and cause complications later with filling.
I anticipate they will follow this patient as an outpatient rather closely, given the finding that we see there. All right, let me show you another rather dramatic aorta case. So this patient has a history of a remote surgical myocardial revascularization procedure. She presented to the outside hospital with symptoms. I don't know what they were, but a very dramatic radiograph, very consistent with a very large aneurysm of the distal aortic arch, descending aorta, and/or complications of it. Here, from the outside, is the non-enhanced portion of a CT. And certainly down here, alongside this very big abnormality involving the aorta, here is hyperattenuation abnormality, consistent with hyperattenuation blood, and certainly outside of the lumen, probably outside of the lumen, of the aneurysm, because here are some internal calcifications. I'll show you the contrast in a moment, but I do want to show you that more distally, where the aorta is very dilated, here are internal calcifications, but in this non-contrast, there are calcifications presumably related to thrombus in that dilated aorta. So I will show you the contrast portion, and indeed you will see here where the leak is, and it's pretty scary, but here is the aortic aneurysm with thrombus. Here is the leaky to that area. So a very leaky, complicated aortic aneurysm case. So of course they proceeded very quickly to surgery. I'll put up excerpts of the op report here and show you a post-op exam alongside it. So they obviously will do a TEVAR procedure to the aorta. Before they did that, they did a left common carotid to left subclavian bypass, so they could readily put this in a proximal landing zone that excluded the left subclavian artery, having done, before that, a bypass between carotid and subclavian. And then they put a series of overlapping multiple grafts, endovascular stent grafts, as you can see here, into the aorta, and that took care of the leak. There was one finding I saw here on post-op imaging, which otherwise looks fine, and I really don't know what this means, but there's a very small collection of contrast medium there, just in relation to that stent, but it doesn't seem to go anywhere. So if that's some kind of endo leak, I'm not sure where it's coming from or exactly what the significance is in relation to the stent itself, but it's small. And of course, they were just observing that. So certainly saved this person's life with this TEVAR procedure. And I think surgeons are really lucky to have this as an option to treat patients with this kind of devastating leaking aortic aneurysm. All right, Jeff, those are mine.
Okay. Okay, so that means I am up. Let's see. Let's do the screen. There we go. Okay. All right, so let me start with this first case. So this is a good case, interesting case. I'm glad you guys are on to talk about it with me. So this is a 50-something-year-old male that presented with acute onset abdominal pain that radiated to the back and arm, and well, both arms. And so presented to the emergency department, and there was concern for an acute aortic process. So I have a 3-phase CT here, and I'll start with the non-contrast. And you can, I'll change the window a little bit, but you can already see early on there's a little bit of hyperattenuation in the wall. So I make a little contrast here, but also you'll see some displaced intimal calcifications, and we'll go down into the belly. A couple other just displaced calcifications. There's one right there. And as we go down, brighten it back up a little bit. Right there, you can see one there, and et cetera, et cetera. It goes all the way down, some abnormal ones. So even on a non-contrast, that's an important finding. And then here's the arterial phase, and I'll come back, I think, to the non-contrast, but also in the delay. So clearly you can see there's an abnormality of the aorta. Let me make it a little bigger for everybody. And so we can see differences in flow. We can see there's, well, it's like an intramural hematoma. And then eventually, as we move further down, we'll see that there's 2 channels. And you can see a true and false lumen with slow flow in the false lumen. In this dissection, there becomes more clear with better flow in the false lumen as we go down. We'll see that the visceral arteries all are perfusing well. They all come off the true lumen except for the inferior mesenteric artery, which comes off the false lumen right there. But everything's open, and it goes out to the iliac on the right, all the way down there, and then kind of fizzles out. So acute aortic dissection and a component of intramural hematoma. The question, though, of course, is it a A or B? And this is where it gets to be a little bit challenging. So if we go back up, we'll point out that I think the distal arch is a little thick in here, and then it does extend into the little bit of the subclavian wall. And we'll go to the delays now. And I think there you can see a little bit better. Let me go up. There's the, see the subclavian involvement, but I think I'm going to make a sagittal. I think you can see the, hold on, it's loading the 1,000 images here. But there we go. Now we can make a sagittal. We'll see that I think it does track back along the arch. We'll go look at the area of interest here. And you can see, so there's the dissection flap, no question. It stops at the subclavian. But I think if you look carefully, let's see if I can find it. There right here is a component of intramural hematoma. And I think it even extends down here into the proximal distal arch. What made this case a little challenging is there's a superior pericardial recess that comes up pretty high. You can see right in here. But I think this is actually involving a portion of the ascending aorta, definitely a component of the arch. So, you know, what do you call this? I think what happened is it's effectively a type B, but it is extended retrograde into the arch and recessity.
So the arch involvement doesn't matter though. It's still a
right,
type B.
but I think it's come back into the ascending as well, right into here. Let me make a coronal.
I don't know. I guess I'd call it a type B with arch involvement because it would still be managed conservatively.
That's what, yeah, they didn't, yeah. I didn't give it a name actually. I just was very descriptive. But if we come anterior, it's just, there we go. You can see right here.
Yep, this perhaps retrograde involvement.
That's what I think is happening. Yeah, and there's no end organ ischemia. So with you know, just conservative management. But, you know, this is one of these trouble ones because technically there is involvement of the ascending, but it doesn't look like it arose there. It looks like it tracked backwards.
Right.
So.
Yep, type B with retrograde involvement of aortic arch.
Yeah.
And a bit of ascending aorta.
Yeah. But it's kind of neat how it sort of evolves from a intramural hematoma into the, you know, just along the spectrum into the full-blown dissection. So.
Yes.
Okay.
Yeah. Well, Jeff, before we leave this, I talked to the Stanford surgeons at the time that this Stanford classification of A and B was derived, and they said that if it involves the ascending aorta, even if it starts distally and extends retrograde, they still consider that a type A because the ascending aorta is then compromised, and that's within the pericardium, and it has, you know, all the complications that go with ascending involvement, including the possibility of tamponade, because the ascending aorta is in the pericardium. So, you know, the classification isn't very good, but they consider that a type A.
Okay. Yeah, I mean, that's their definition. But I don't know about. Go ahead.
That's not uniformly held, David. In other words, there are some surgeons that will not treat this kind of retrograde involvement of the aortic arch with surgery in the same way as a conventional type A. So that opinion is not universally held. Most of the time, they will just observe that in the absence of malperfusion syndrome, for example.
I've also seen, especially in some patients, they're, you know, well, non-operative ones are different, but sometimes they'll treat some of these a little more conservatively depending on, you know, the extent of the involvement. I'm not convinced. I don't know. I thought it was involving at least the distal ascending, but maybe our surgeons thought otherwise. But it was a good story from pretty classic clinical presentation and you know, a good observation on part of the emergency department. But yeah, it wasn't just your slam dunk type B that starts distal to the arch and goes. Okay, this is a case that was at one point was transferred to us for management of a pleural effusion, and the only history I know about, I don't know the full story, was that the patient had a recent coronary angiogram, and what actually is the case is it's more than just a pleural effusion. We're going to talk about this finding here, and if you measure the density of this pleural collection, it's about 40 Hounsfield units, and clearly there's dense material in the prevascular space of the mediastinum. So if we look carefully, the patient does have an aortic valve prosthesis in place, but there's this pseudoaneurysm right near the origin of the right coronary artery with you know, bleeding into it. So makes you wonder if this has presumably happened during the angiogram itself. Now, whether it's from an injury or the valve is somewhat dehiscent, although I think it's far enough away from the valve, it probably isn't the valve. but presumably iatrogenic. Now, why there's a big hemothorax, I don't understand completely. You know, sometimes these things near the aortic root are easy to walk by if you're not paying attention to them or if you get distracted by something. But this was unexpected upon arrival, that there was actually a big giant pseudoaneurysm. I'll show the coronals. I think coronals are even easier for showing this sometimes. There's the valve, and you can see the valve looks pretty well seated there, but there's this extra collection. We've seen really big ones that almost look like a left atrium because they're so big. But I don't know, we don't see that very often.
Had the aortic valve been placed, Jeff? Was that?
I don't know, but it wasn't recent if I remember correctly. I think it had been there for some time. Well, I can look at the sternotomy wires. Yeah, there's osseous union of the sternotomy, so it had been a good while. That's one way to tell. There's a nice example of the little pledgets or felt that you sometimes see when there's been aortic surgery. So it has a good example of that. And that's not the pseudoaneurysm, but yeah, right here at the root. So I presume during the angiogram, for whatever reason, there was an injury to the sinus of Valsalva, and then you just have this contained collection there. And how the hemothorax occurred, I don't know. But yeah, just got to be aware of those. It's a rare complication, but it does occur. Okay, here's another non-COVID case. Let's see. So this patient is an 82-year-old, and let's see. I'm missing the. I don't have the other PA, so we'll skip that one. Well, this is kind of cool. So this patient had a heart transplant some time ago, and as a complication of the surgery, developed osteomyelitis of the sternum, which does occur sometimes, and with a potentially higher rate with the transplant just because of immunosuppression. And so you can see there's no sternal wires. And then what they did to fill this space in here, they drained the retrosternal abscess. And I've not seen this done this way before, is they brought up this muscle flap. And this is a rectus flap. You can see it comes off here, the right rectus sheath. And they just brought it subxiphoid into the, it's clearly, brought it up in the prevascular mediastinum to sort of separate the heart from the pericardium from this. And it's done quite well. You can see the bones now at this point are corticated. There's no residual abscess, and there's even starting to be some osseous union here. So, I've seen all sorts of muscle flaps, but I don't recall seeing a rectus flap brought up in the mediastinum like this in a long time, or I don't even recall one now that I think about it. I don't know. Has anyone else ever seen this technique used?
No, not in that location. No, I haven't.
Yeah.
Part of the rationale for that is to fill the space, but also to have very vascular tissue to bring a very good blood supply there to fight any ongoing infection. So it's partly to have a very well perfused thing there to help fight recurrence.
And I think one of the pitfalls is if you're looking at this and not quite aware of what's going on, you might misinterpret this as a hematoma.
Yeah.
It's very dense and kind of strandy looking, but yeah, the rectus is a pretty big muscle. I've seen omental flaps brought up. Those are pretty easy to do, and there's some recent work showing the omentum itself probably acts as an immunologic organ and can help. But yeah, this worked quite well. If it's more external, they usually have to bring a flap to cover the anterior chest wall. They can mobilize the pectus and cover it with that. I've seen that done. Of course, a rectus flap, little bit of loss of function, but you still have the transverse abdominis and the obliques and the other rectus there. But yeah, a simple one, and I think it looks like it's not a free flap, but rather on a pedicle, and they just rotated it up. And then on the you can see it really well on the sagittal. Should show here. Here we go. There you go. Nice muscle flap coming in. So a little new technique, or a technique I haven't seen. Okay, this is a great case, and this would be a good one for the residents on there. So, a good boards case. I remember it would be a good one you might have seen in Louisville back in the days. But patient presents with a radiograph like this and shortness of breath and massive hyaline. And then if you look on the lateral, you can indeed see it's the pulmonary arteries that are big. Go back to the front, and you see the main pulmonary segment here is bigger than the aorta. The aorta is up in here. And then the elevated apex of the heart, consistent with a right heart enlargement, and then the filled-in retrosternal space. So all good findings of pulmonary hypertension. I apologize, I've got a lot of glare on my screen. I can't tell if we can see any calcium in there or not, but Here's a CT showing this, and you can see there's a lot of in situ thrombus or probably atheroma, and then atherosclerosis. And I remember David teaching me, when you see this, it means it's been there a really, really long time. So in an adult, you have to think about, okay, long-term pulmonary hypertension, you have to think about a shunt. And indeed, there is a shunt here, and it's actually kind of hard to see. But right here, you can see there's a pulmonary vein coming in, and it's draining into the superior vena cava. And then as we scroll down, we can see the communication between the SVC right atrium and the left atrium here. So this is a superior sinus venosus type atrial septal defect with long-standing severe pulmonary hypertension. So this is Eisenmenger syndrome. And if we look at the lung windows here, you can see there's heterogeneity of them. Get a better, there we go. You can see a little bit of heterogeneity and the sort of rapid pruning of these pulmonary vessels more distally. So these do occasionally still come through, untreated. But this is usually these sinus venosus don't cause a huge amount of shunting to cause this much pH. I don't know if
I'm surprised by it.
Yeah, but and I don't know if it caused maybe functionally to open a PFO or something that contributed. You can see how big the RV is, how hypertrophied it is, and look at the bowing of the septum there. It's quite impressive. So this is not PE. This is not a sarcoma.
So you do have anomalous pulmonary venous return up there too, contributing to it.
Yeah, that's the major portion of it. Yeah, that was the first finding you can see as you scroll down. You see that coming in there.
Sorry, I missed if you said that earlier.
Yeah.
Jeff, how old is this person?
I don't remember. I want to say 40s or 50s.
Really, that young?
Yeah. Okay, but that was interesting. Yeah. So pretty classic pulmonary hypertension case. Okay, so this is just it's something we don't see a ton of, but something to be aware of, especially for the trainees on there. So this patient presented with this sternal mass. You can see it's expansile, lytic. It's got some matrix inside it. Mets, myeloma typically, but this is a primary tumor, and this is actually the most common primary malignant tumor of the chest wall, and it's a chondrosarcoma. And the majority of them occur, about 2/3 of them occur anteriorly, so along where the ribs are. And I've seen a handful in the sternum now. And they can be low grade like this one is, where there's mostly intact and they just slowly grow over time. And there is some matrix in it. If you didn't have a matrix, you'd have to include a plasmacytoma and, of course, something like a renal cell, thyroid met. This was a relatively younger patient. I think she was in her 30s or something. So this is treated by primary resection. Chemotherapy is typical for sarcoma. And because it's a lower grade, the risk of metastasis is lower. So there are some primary malignant chest wall tumors, mostly sarcomas, including chondrosarcs, and then osteosarcs are much less common. More common to see those as a secondary tumor. And she's on the younger end, so more likely to be a primary tumor. And then an older patient, maybe one who had radiation, you can see a secondary sarcoma there. I'll just make a sagittal real quickly, show the lesion there, but it presents typically as a palpable mass. But pretty good example. Okay, this is something I have not seen since I was a resident. And I don't have a biopsy of the lungs, but I have biopsy elsewhere. So this is I think, how old was he? Oops, here I go back. 53-year-old male with known HIV, poorly controlled, and has cutaneous and I believe GI Kaposi sarcoma. And so this was done looking specifically for pulmonary involvement, which of course is common. And I'll draw your attention because the findings are fairly subtle. Is you've got these what look like little nodules, but you'll notice they're associated with these vessels. And they're kind of shaggy looking. There's a little one there, and I'll scroll down a little bit. And you can just see them kind of popping up. There's another little shaggy vessel there. And so the classic description of Kaposi sarcoma in the lungs are these perivascular sort of flame-shaped, I think it was a nice way of saying sort of shaggy margins, sort of opacities, I'd call them more like nodules. And as this tumor often gets in the lymphatics of the lung, and it can also be a sort of a vascular tumor. But the presumption is this is Kaposi's of the lung, very mild case of it, but I think there's convincing findings like that and that there. David, you've probably, and Howard, you guys have probably seen a lot more of this when HIV was less well controlled than it is now. But I think I saw a couple cases, or maybe it was the same case twice in residency, but I really haven't seen it since.
Yeah.
But
Yeah.
it's in the
You live a sheltered life up there in Wisconsin. I still see it occasionally, and I certainly saw it at Grady.
Yeah.
But now you're living in the, in the HIV capital of the world. So,
Yeah.
the nodules are usually irregular and sometimes stellate. They're not smooth, like metastatic looking nodules with nice, spherical.
On this MIP, I think you can see sort of the shagginess of them.
The flame shape,
because the way that it grows.
The flame shape business really is more dramatic in the cases that are central around the hyla, where you get these sort of radiating spikes going out into the lung from the hyla. It really does look flame-like, sort of extension into the lung.
Yeah. But the distribution is very helpful in this case. Now, if I didn't have any history, I don't know what I would call these, but KS is just not something in my differential diagnosis anymore. But David, correct me if I'm wrong, when they have lung involvement, don't they almost always have cutaneous involvement?
I think so.
Okay.
Sometimes they see it in the airway too. So sometimes the bronchoscopist sees it on the way down.
Yeah, and it's now classified as a neoplasm, multicentric neoplasm, and it's associated with the KSV virus, which is, if I remember, a human herpes virus.
I think so, yeah.
HHV8, I think.
Yeah.
Or 6 or 8.
Okay, and then Vasilio sent me this case just yesterday. This is a case that sort of ties a bunch of things together. So the patient has a pneumothorax, and the consolidation will come back to, but has these fairly thick-walled cavitary lesions in both lungs there, and a lot of them are subpleural. So we've seen cases like this, and then right there you can see one of these has decided to rupture into the pleural space, hence the pneumothorax. And any cystic thing can, of course, do that. But these have thicker, irregular walls, and of course, metastases could do this. But this patient has a history of rheumatoid arthritis. I wonder if that's re-expansion edema or some other infection there. But a nice example of that, rheumatoid nodules, and I think I've shown a case where we got a pneumothorax before. I can check the email in a second, but he also had asked about a finding in the bone. I didn't see any bone findings. Their question was in the humeral head. I'm not sure that's an erosion there. I think that may just be, I don't know if it's just related to degenerative stuff. And then there's just or a little old injury, but maybe, I don't know. Typically I look for them around the clavicles, the AC joints. They look pretty good. But yeah, a nice example of rheumatoid nodules in a patient with known rheumatoid arthritis. And in this case, maybe even hemorrhage, I don't know. But the ones we've shown are often out in the lung periphery. So I think it's not surprising that they would cause a pneumothorax, but it's really nice when you can actually see the communication there.
Yeah, very much so.
Let me just pause that for a second. Let me pull up the email. I can see if there's any more history in there. Yeah, we got that. And yeah, that was thought to be re-expansion edema there. So yeah, I think it all ties nicely together in a rheumatoid arthritis case. All right, that is all I had. I had one more. I had one more case, but I seem to be missing the frontal view, which is kind of key on it. So let's see, unless it's.
I can show one more that is not.
Oh, actually, I do have it. Okay, I'll let you go.
No, I can go next time.
Okay, this is quick, and we probably still have time. So I did have it. It was just hiding. So this is importance of comparisons, and it's set with and devices. So let me open that PA and this PA. So you'll notice. Let's see if
I'm not seeing a screen.
Oh, I got to hit the share button. Sorry. Thank you. Why is it not letting me share my screen? I'm going to make someone else the presenter real quickly, and then I'll take it back, and then it'll let me share my screen. All right. Now, you see two radiographs?
Yep.
Yes.
All right. Get this out of the way here. Okay. And let me see what the... So yeah, so these are 3 months apart, and you'll notice the orientation of this generator has changed. And look at the wires in there. And not just has it rotated, it's actually, if you were to rotate this in your mind, it's actually a mirror. So it's flipped in the pocket along the z-axis here, so that the orientation of these leads is going this way. So they're coming out of the generator and wrapped around and going this way. Whereas here, they're coming the opposite way. They're going clockwise and coming out. So this is an example of a flipped generator within the pocket. And it can happen in larger patients, or if there's a lot of subcutaneous fat, and particularly early on after placement when there's a lot of, it's mobile in the pocket. We've talked about Twiddler syndrome where it winds up and it can dislodge the leads. But in this case, the generator actually did a 180 along this axis here vertically. So always important not just to check the lead position, but also the position of the generators. Because you can see this, it can unwind. In this case, let's see if I remember, yeah, this was the later one, so it wound up a little bit, so it runs the risk of starting to tighten up on, put tension on these leads and could potentially dislodge them.
Yeah.
All right. Now I'll switch it over to you, Howard. Sorry about that. There you go.
Okay, this one is an example of, just a nice example of the situation in which if you have a patient with severe bullous emphysema and the patient has new symptoms and there's a question of a pneumothorax, what might you see? So this is the previous exam. Just be sure of that. And you can see very extensive bullous emphysema. And let me show you now the current one. When the patient was symptomatic. And here on the left side is a nice example of what's called the double wall sign. So if you see the cystic spaces and you see both walls of a cystic space, the anterior wall parallels but is separate from the visceral pleura. Now this one's pretty obvious because the amount of pleural area is quite large. But imagine the situation where the amount of pleural area is small and these walls of the bulla are much closer to the parietal pleural surface. It may be hard to distinguish between bully and pneumothorax. So here very clearly you can see what is called the double wall sign of pneumothorax in the presence of severe bullous disease. So again, you can see that down there because there's so much pleural air. But sometimes, as you know, I'm sure you've had the experience where you can't tell and you really don't want to put a chest tube into a large bulla. But if you see what is called the double wall sign, again, where these margins are separate from the parietal pleura, then, unlike here, for example, then you can diagnose a pneumothorax. So double wall sign, so-called, of that. And here is the article talking about the usefulness of the double wall sign in detecting pneumothorax. Again, here is the anterior wall separate from the parietal pleural space, parietal pleural surface, excuse me. Not usually a problem, but once in a while it is. And I find that useful once in a while.
Yeah, thank you. That's actually a good case because sometimes that becomes a we occasionally get a case probably once a year or something like this, and it can be really challenging. especially if you're less experienced with it. I find also looking on sagittals can help you as well. Just you can see how the lungs, or even a coronal, how the lungs pulled away from the whole surface.
Yeah, this one, of course, is much bigger and it's easy to tell. The diaphragm's even slightly inverted there. All right, Jeff. Very good.
All right. Well, it's the top of the hour. Thank you, everybody. It's nice to have a nice big live audience. And everybody, please be safe and stay in place wherever you're supposed to be. And we'll talk to you next week.
Thanks, everyone.
Thanks, everyone.
Thank you.
Thank you.